Welcome to Horizon Medical Education Podcast, concise, evidence-based audio lessons for clinicians worldwide. For supporting notes, accreditation, certificates, and access to all our courses, visit our platform at www.horizonmedicaleducation.com. And just as a reminder, this podcast is intended for medical professionals and for educational purposes only. It does not replace clinical judgment or local guidelines. Episode 6, Ebola Part 3.
I'm Fran.
And I'm Minnie.
And we welcome your feedback on this course.
And our tip today is treat patients with respect and dignity.
So important, Minnie, particularly because it's such a terrifying disease for people who have it, and they're being treated by, people wearing these enormous gowns and face masks and PPE. So it is, it's a really scary thing to be going through. So this is part 3, and we're going to go on and discuss additional complications. We've talked about some in part 2, prognosis, long-term sequelae, so that's long-term consequences, immunity and vaccines, and just give a couple of case examples of presentations for you, our learners, to go off and just sort of have a think about how you might approach their treatment.
But we'd give you a quick reminder that there are 3 different viruses known to cause large Ebola disease outbreaks. That's the Ebola virus, the Sudan virus, and the Bundibugyo virus, which is the one that's causing the current outbreak. The average Ebola disease case fatality rate is around 50%, and early intensive supportive care with rehydration and the treatment of symptoms really does help improve survival.
So, Minnie, in part 2, we discussed some of the specific therapeutics for Ebola virus, how they've got these drugs, and how the success rate depends on how early the treatment is administered and also the patient's viral load. And so I was like, I wonder what the actual improvement is. So I appreciate this. We were talking about this in part 2, but I thought this is kind of interesting. There are 2 approved monoclonal antibody treatments, which we discussed. There's the RGN-EB3 and the MAB114. And they result in an average survival rate of about 65 to 66% overall. So remember, this is Ebola virus disease, which is the most deadly of the 3. But survival jumps to 89% to 94%, which is a huge increase if patients are treated early. And that just, that's amazing. And it just goes back to the thing that we've been saying all along, isn't it? That people must present early. They must get to health centres early if they think that they have Ebola disease.
Absolutely, yeah. And we thought we'd also, while we were thinking about treatments, we thought we'd look at the emerging treatments for Bundibugyo virus disease. Recently, the WHO had a technical advisory group on therapeutics prioritization for Bundibugyo virus disease. And as we discussed last time, one of the major challenges in this current outbreak is that, unlike Ebola virus disease, as you said, Fran, there are currently no licensed treatments specifically proven to work against Bundibugyo virus disease. So as a result, they've convened this advisory group in May of 2026 to identify the most promising therapies for urgent clinical evaluation. So it's really quite interesting and really important. So the group reviewed available laboratory, animal and human safety data and focused on 2 main categories of treatment. So they looked at the antiviral drugs, and these are things that inhibit viral replication. And they also looked at the monoclonal antibodies, just what you were talking about, Fran, which target and neutralize the virus.
Let's talk about the antiviral therapies first. So remdesivir emerged as the leading candidate for treatment. Whilst clinical data in Bundibugyo disease are lacking, it has demonstrated antiviral activity against filoviruses, from which Ebola is one of these, and has an established human safety profile from its use in other viral infections.
It does get brought out every time, doesn't it, as a potential
treatment. Yeah, absolutely. And then the oral antiviral obeldesivir was identified as a particular attractive option for post-exposure prophylaxis because it can be given orally, making it potentially easier to deploy in outbreak settings. So the WHO experts prioritized it for clinical trials in people recently exposed to the virus.
And that would be amazing, wouldn't it?
Yeah. And I think, gosh, when you were telling me about all of this, I was like, I mean, maybe it doesn't seem quick if you're on the ground and you're dealing with the Ebola virus, but from my point of view, the fact that they've already got all these experts together and have already gone, right, what have we got? What's the information that we've got? Right, let's put it into clinical trials. Let's do this. Feels really proactive
and much more than in previous times.
Absolutely. And, whilst COVID was an awful thing to happen, I think that did show how quickly, when people put their mind to it, medicines can be brought into trials and evaluated to see whether they're going to work or not quite quickly, when the will is there. Yeah.
Yeah. So let's look at the monoclonal antibodies that they've thought about. The monoclonal antibody cocktail MBP134 was highlighted as one of the most promising therapies currently available. So in animal studies, it has shown activity against all three major Ebola-causing viruses that we've talked about before. So raising the possibility of a sort of future pan-Ebola virus treatment, which again would be amazing if you had just had this one treatment that would treat any Ebola disease-causing virus.
Yeah, because you could get on and treat it even before you knew which species it was.
Yeah, exactly. Yeah. And there's another promising candidate called maftivimab, which we remember is one of the components of the licensed Ebola treatment in Mazeb that you talked to us about, Fran. The laboratory studies here suggest it has activity against Bundibugyo virus, so it could potentially be effective as a single agent therapy.
And then thinking about sort of combination therapies, moving on from there, just as HIV and TB are treated with multiple agents, there's growing evidence that combining an antiviral such as remdesivir with a monoclonal antibody may improve outcomes by attacking the viruses through different mechanisms. This was a particularly important direction discussed by the WHO. As a result, WHO has prioritized clinical trials for treatment evaluating remdesivir, MBP134, maftivimab, combination therapy using remdesivir plus monoclonal antibody, and this is high priority research strategy, and obeldesivir for post-exposure prophylaxis. So these are the ones that they're really looking at. However, not to labour the point, but that we know for now, supportive care remains the most important aspect of treatment.
On the transcript, we've just put the link to that, the full details of that advisory group meeting report. So if you're interested, do have a look.
So let's move on, Minnie, and let's talk about some of the additional complications. Whilst Ebola, it's thought of as a hemorrhagic fever, and we discussed how actually not that many people hemorrhage. It's a disease that the deaths result from lots of different complications affecting multiple organ systems. And so we're just going to talk about some of the complications that result indirectly from Ebola infection and from the severity of the illness. So the first thing that I'm going to talk about is acute renal failure or acute kidney injury. And this is a really serious, really common complication of Ebola virus disease. And the causes are often multifactorial. Data from the West African outbreak suggests it is a mixture of pre-renal, so before your kidneys, causes. So that, for example, is hypovolemia from severe dehydration from diarrhea and vomiting, and that then leads to severe hypoperfusion of the kidneys. And then there's also intrinsic renal disease, so that's acute tubular necrosis related to severe hypovolemia, hypotension, acute tubular necrosis, possibly direct Ebola virus infection or myoglobin pigment damage. So you've got this, problems affecting your kidneys from before it gets to the kidneys. So it's other things indirectly affecting the kidneys and then problems within the kidneys.
So that myoglobin pigment damage is from rhabdomyolysis, isn't it? Breakdown of muscle.
There you go. So there's lots going on. Sorry, as a bit of an aside, acute kidney injury is something that certainly in my practice and the hospitals where I work, it's much more highlighted. So I think before everyone would be like, oh, they're just a bit dehydrated. But now we actually have, we can score how well kidneys filter with people's EGFR, and more what we're noticing is patients going into hospital that it's actually a really big part of their illness, that their kidneys are affected by, very often actually it's dehydration and hypoperfusion. So it's interesting, isn't it? But in many outbreak settings, well, they don't have access to the blood test that I would have, but access to renal replacement therapy is limited or unavailable. So what you want to be doing is you want to be preventing the acute injury as soon as possible, all the complications of it. You want to be on it straight away, which is why, again, patients presenting early is really important, because then you can stop it from becoming a problem. So, we talked about fluid status, didn't we, and about how dehydrated these patients can get. So close monitoring of fluid status for volume depletion, early correction of hypovolemia among the most effective interventions that clinicians can provide.
It's the correcting the initial depletion and then keeping on top of the ongoing depletion as well. I think that is really crucial in the same way as we saw in cholera.
Yeah.
And then on the transcript, there's a little infographic which just talks a little bit more about general considerations to do with the kidney in your management.
Yep. Brilliant. About, correcting dehydration, monitoring output, looking at your electrolytes, isn't it? Avoiding nephrotoxic drugs, dosing drugs appropriately according to, people's kidney function. Yeah, it's really useful. Have a quick look. Yeah.
So the next complication to look at is metabolic acidosis. We know that patients with Ebola are at high risk of developing metabolic acidosis due to a combination of both the large volume diarrhea, shock, sepsis, and the acute kidney injury. So this can contribute to worsening organ dysfunction and may present clinically as tachypnea, so that's rapid respiratory rate, and increasing physiological deterioration. So if you can, a blood gas analysis is really helpful in identifying this and helps you to monitor the severity of the acidosis.
So next, thinking about hypoxic respiratory failure. Acute respiratory distress can occur for multiple reasons, and not all breathlessness is reflecting primary lung disease. So if hypoxia is not present, then rapid breathing may be a response to pain. It may be that the patient is in shock, or it may be, like you were just talking about, Minnie, metabolic acidosis. And then if there is hypoxia, we'll think about complications, because we know it doesn't typically affect the lungs, but if you've overloaded the patient, you might have put them into pulmonary edema, there might be renal failure, they could have got a secondary bacterial pneumonia, which we talked about, didn't we, in part 2, hemothorax, occasionally bronchospasm associated with anaphylaxis, so perhaps they've had a reaction to one of the drugs that you've given them.
Pregnancy remains particularly high risk in Ebola, so one of the complications is miscarriage and maternal death for those that are pregnant. Ebola infections associated with a high rate of miscarriage, and maternal mortality is significantly higher than in the general population. Management is often challenging because the physiological demands of pregnancy coexist with severe infection and hemodynamic instability. I mean, it must be a really difficult clinical situation to deal with.
Yeah, you can't begin to imagine managing that. Yeah. Malnutrition, we talked about nutrition and how important it was, didn't we, in part 2, but patients with Ebola can lose substantial weight during the illness due to prolonged catabolism, reduced oral intake, and gastrointestinal losses. So early enteral nutrition should be encouraged wherever possible, and nutritional support is an important component of recovery as well as supportive care. So, think of it as a longer term ongoing problem, even when people are leaving their isolation.
And that leads us quite nicely onto sarcopenia and pressure sores, actually, because critically ill patients can rapidly develop muscle wasting. So that's the sarcopenia. They rapidly become deconditioned, can develop pressure ulcers and thrombotic complications. So a way of managing this, daily assessment of mobility is really important. Once your patients are improving, that's the time to be encouraging early mobility and ambulation, just to try and prevent these pressure sores and thrombotic events. Things like providing assistance for patients to sit up, get them to dangle their legs out on the side of the bed, then to stand and walk when they're strong enough. And, all these things do mean that you need a lot of staff.
They do, don't they? Yeah.
And for those that are unable to move independently, regular repositioning every 2 to 4 hours helps prevent pressure ulcers. So it's the management of preventing pressure sores and that sort of thing is the same regardless of the cause of why the person's immobile.
Yeah. And so it's interesting, isn't it? So muscle loss from bed rest begins within days of being bedbound and becomes measurable and clinically significant within 1 to 2 weeks. And certainly not in Ebola patients, but in my elderly patients who are immobile, when they get admitted to hospital, unfortunately, they so often come back with pressure sores just from, a short stay, because
it is very difficult to manage.
It's really difficult to manage, even with these, in the UK, we've got these clever pressure mattresses and, we do have reasonable staffing, but it's still a massive risk for anyone who is bedbound. Thinking about the psychological impact. So it is profound and often begins during the acute illness, which is why we were talking about, respect and dignity is so important whilst we're caring for these patients. Healthcare workers need to develop trust and good relationships with the patients and their family. As I said, they're being cared for by staff wearing really quite extensive PPE. And obviously I'm not there in the setting, but we've seen photos of, sadly, people in PPE at funerals, carrying the caskets and things. And it's almost sort of otherworldly, isn't it? That can be really frightening and really isolating for patients. So, really simple things that people could do, could you write your name on your outfit or your personal protective equipment so patients can recognize you, and then they'll be able to respond better to you, if you've got the ability to put up pictures of healthcare workers on the walls of treatment areas. So, there's a human behind that PPE. As much as possible, allow patients to communicate with their friends and family. Now, obviously, that's got to be safe, but that's really going to reduce the psychological distress, not just to the patient, but also to the family. You need to do that without increasing the risk of infection.
Yeah. And Fran, the effects do continue long after discharge, don't they?
Yes.
Survivors, orphans, and bereaved families may face stigma, social exclusion, and, as is so often the case, economic hardship in many communities.
Yeah.
So if you can consider, and if you have it available, consider psychological counselling longer term to sort of look at these concerns and to support people. Problems that people have include depression, anxiety, post-traumatic stress disorder, and we know there's a sort of post-intensive care syndrome, isn't there?
Absolutely, yeah.
Obsessive compulsive disorders, even substance addictions and suicidal tendencies can all occur as a result of this illness. One statistic shows that approximately 20% of survivors are diagnosed with depression.
Oh, I can't begin to imagine. Yeah. And I think, if you think for lots of them, it's not just going to be that they had the illness and they've survived and possibly they have the stigma, but the likelihood is that people around them had the illness and have died. So,
Yeah, exactly.
they've got that bereavement and grief to deal with as well. I mean, it's extraordinary that it's only 20%, if I'm honest.
Yeah.
And then thinking about palliations, palliative care is an essential part of Ebola management, and we shouldn't be viewing it as end of life care, because palliation is more than that. So palliative care allows for the prevention and relief of suffering by means of early identification, repeated assessment, and treatment of pain and other distressing symptoms, plus, possibly discontinuation of therapies or interventions which may be painful. So pain, dyspnea, so that's shortness of breath, nausea, vomiting, body aches, respiratory distress, bleeding, and encephalopathy are all symptoms that really can contribute to the suffering of patients with Ebola virus disease. So assessing them and then relieving them when you can not only improves patient comfort, it preserves their dignity, and it supports both patients and families throughout the illness trajectory, regardless of the prognosis. And that's something that I hear quite a lot of, palliative care, like, my patients are really distressed when they have seen their family members in pain. That's such a big thing that people carry, like, why wouldn't they just stop their pain? So, if you can stop it, give them medicines to help them. And
I think agitation is another symptom that's really distressing for those around someone.
Yeah. And also, we talked about this before as well. When somebody is agitated, it risks the transmission of Ebola because they are thrashing out and risking contaminating or tearing the PPE or whatever. So it's also protecting the staff by treating them. So, that's all really important.
Yeah. Okay, let's move on to thinking about prognosis. I mean, the prognosis of Ebola disease varies considerably depending on the virus species, which we've seen, and critically the level of supportive care available. So the pooled case fatality rate globally has been estimated to be around 60.6% based on data that runs from 1976 to 2022 for 16 countries and looking at 42 outbreaks. The Ebola virus, as you mentioned, Fran, this is the most serious. This has the highest case fatality rate of 66.6%. Then it's the Sudan virus at 48.5%, and then the Bundibugyo virus, which is 33%, which, compared to the others seems quite good, but still it's a very high fatality rate for a viral
1 in
outbreak.
3. Yeah, it's 1 in 3, isn't it? And so one of the strongest determinants of outcome is access to medical care. Higher case fatality rates may be related to the supportive care that's available in resource-poor rural settings where outbreaks have typically occurred, and reflects the difficulties that patients in these settings have in accessing basic medical care in the healthcare structure that quite often is overwhelmed. And I think
particularly in an outbreak,
particularly in an outbreak, and particularly we know at the moment in this current outbreak in the Democratic Republic of Congo, where there is conflict, that is, everything is just really overwhelming.
And by contrast, mortality is substantially lower in high-income settings where there's advanced supportive care, including intensive care and organ support. But despite this, fatalities occur approximately 20%.
Gosh, so even with
still,
best care,
yeah. But importantly, we know that early treatment saves lives. Prompt recognition, aggressive rehydration, and correction of the electrolyte abnormalities and management of complications can significantly improve survival. There was an observational study actually on an outbreak in 1995, which showed a marked decrease in the case fatality rate from 93% to 69% between the initial and final phases of the outbreak. It's really interesting. So this suggests that the later cases were recognised earlier and possibly, as clinicians gained experience in managing and treating patients were identified and treated.
I mean, that kind of makes sense, doesn't it? Because the first few cases, you're not even going to know they're Ebola. You're going to be like, oh, somebody came in, they had a terrible virus, they got poorly. And then you'll be like, oh, hang on a sec. I've got another somebody and another somebody.
Yeah,
and then you're going to realize. So, that seems like that's predictable, doesn't it? That people would get better at treating it. But we also know that certain groups are at particularly high risk of poor outcomes, don't we? So children under the age of 5, adults over the age of 40. So, adolescents and younger adults do better. Women tend to have a better survival rate than men, except pregnant women, which you mentioned, didn't you, Minnie, in whom there's this high incidence of miscarriage and maternal mortality. No data yet on the effect of HIV on prognosis are available. So, we're still waiting for more information on that. So interestingly, the timing of the illness also tells us a bit. So patients who survive beyond the second week of infection then have a more than 75% chance of surviving, whereas those with fatal disease typically deteriorate very rapidly, with median survival of approximately 9 days from symptom onset.
Pretty quick, isn't it?
Yeah, it's really quick. But, if you've made it past the second week, then it shows that you're probably doing okay.
Yeah, but recovery can be prolonged, and patients discharged from the isolation facility when they're ambulant, though, when they're about self-caring and lack significant symptoms, for example, diarrhea, vomiting, bleeding, and have, crucially, the 2 negative reverse transcriptase polymerase chain reaction results taken 48 hours apart. So we're going to talk a little bit now about this prolonged recovery, the long-term sequelae.
One of the most important lessons that we've learned from outbreaks is that survival doesn't necessarily mean full recovery. And, this goes for lots of illnesses, but many patients experience what is now called a sort of post-Ebola syndrome, which is a constellation of physical, neurological, ocular, so eye, and psychological complications that can persist for months or even years after the acute infection has resolved.
Yeah, recovery is often slow and characterized by profound fatigue, weight loss, and persistent musculoskeletal pain. In fact, Fran, when you and I were talking about this, we were saying, well, that's really common after so many infections, isn't it? And viral infections particularly.
And I think previously been really quite ignored by clinicians, if I'm honest. They're like, you've got over the Ebola crack on, or you've got over your COVID crack on. But actually, I think we're much more aware of it. I think, again, COVID has shown us, hasn't it, that, that there are lots of long-term complications.
And I think as we learned more about our immune systems and how complex they are.
Oh, yeah, extraordinarily. And how clever these viruses are.
Indeed, yeah. Long-term follow-up studies, around 75% of survivors, so that's 3 out of every 4 survivors, reported ongoing arthralgia, often migratory in nature, so that's joint pain, and many continued to experience myalgia, muscle pains, headaches, and abdominal symptoms.
Let's just talk about the eye, because the most striking complication is ocular disease. The eye is considered an immune privileged site. So again, we've mentioned this before, but that means the virus may persist there even after it's been cleared from the bloodstream. And survivors can develop uveitis, so that's either anterior, posterior, or pan-uveitis, which may lead to secondary structural complications, vision impairment, or even blindness.
Studies suggest that approximately 28% of survivors develop uveitis and 3% develop optic neuropathy. In these patients with uveitis, 38% of patients actually were blind. So that's a pretty high proportion of those that develop uveitis going on to become blind. One survivor had acute uveitis with detection of viable virus 14 weeks after the onset of infection and 9 weeks after the clearance of virus from the blood. Unilateral white cataracts and a novel retinal lesion following the anatomical distribution of the optic nerve axons have also been reported. So it really does seem that the eye is, really affected post-infection.
Isn't it? And it's not something that I'd heard of before.
No.
But actually, beyond the acute illness, Ebola can affect virtually every organ in the system. So just some examples are persistent fatigue in around 70% of survivors, anemia, 50%, hepatitis, pancreatitis, chronic abdominal pain, headache, around 50%, neurological complications, including numbness, myelitis, and cognitive difficulties.
Auditory symptoms as well. So this includes hearing loss and tinnitus occurring in about 1/4 of survivors. Reproductive and genitourinary complications like orchitis, erectile dysfunction, loss of libido, urinary frequency, and menstrual disturbances.
That's interesting because COVID did that as well, didn't it? And it wasn't massively mentioned, but that really gave people menstrual disturbances.
Yeah. Dermatology manifestations such as skin peeling and temporary hair loss are also frequently reported. And then the psychiatric complications, so psychosis, memory loss, difficulty falling or remaining asleep, depression, anxiety, and post-traumatic stress disorder.
These effects are often compounded by bereavement of, family members, friends, the community, stigma of having had Ebola virus, and the social disruption caused by major outbreaks, which is huge. And I was saying to Minnie just now that I was reading an article that was saying that how incredibly disruptive Ebola is to the community. So, for example, the motorbike taxi driver was saying, well, he can't get any passengers anymore because nobody wants to sit up close to anyone. So before he'd have 2 passengers on the back of his motorbike. Now nobody wants to share because they know that they can catch Ebola from touching another person, skin-to-skin contact, that the fruit and veg seller says, I can't have people coming and touching my fruit and veg, so I've actually have to stop working. I'm so terrified that I would accidentally pass it on to someone else by, one person touching it and then another person touching it. So, the economic consequences are also enormous, aren't they? So this whole disruption caused by it,
Yeah, and thinking about these long-term sequelae, perhaps one of the most sobering statistics is that around 50%, that's 1 in 2 of the survivors will report multiple persistent symptoms, so that's more than 2 that we've just described for at least 2 years after the infection.
Wow.
2 years after the infection.
It's a long old time, isn't it?
Yeah, it is. The cause of these manifestations is unclear, but could be related to immune complex phenomena or the persistence of the virus in immune privileged sites, as we've seen, such as the eye, the central nervous system, and also in the testes.
And so I think for this reason, we shouldn't just view Ebola as, an acute infectious disease. It's increasingly being recognized as a condition with significant long-term health consequences. And, ideally, survivors should receive regular checkups for at least 18 months after recovery. I mean, I don't know how plausible that is in a setting where there's an ongoing outbreak and healthcare workers have died. I think
healthcare is stretched beyond what it was already.
Yeah, absolutely. Yeah. Sexual health. So I thought this was so interesting, Minnie. Viral shedding in seminal fluid may continue for more than a year and a half after recovery. So the virus was detected in semen in 62% of men 4 to 6 months after recovery from an acute infection. And I think what's also interesting is it may be intermittent. It may not be a constant thing. So one study reported the reappearance of viral RNA in the semen of 30 males after 2 consecutive negative test results. That's just mind-blowing, isn't it?
It is, isn't it?
Yeah, and there's also been a report of sexual transmission of the virus from a man to his sexual partner, which has been confirmed by genomic studies, and that was during the outbreak in Liberia. Equally, the virus has also been detected in vaginal fluid. So what are we going to do? We can't have all these patients, recovering and then going off and reinfecting people accidentally. So WHO recommends that men should be offered semen testing every month. I mean, again, I just can't see how this is going to happen. I don't think I would be able to arrange this in the UK. But anyway, every month from 3 months after symptom onset, and then every month from 3 months until you have 2 negative semen tests taken 1 month apart. And during that time, you need to either be abstinent or use condoms. So until you have 2 negative semen tests taken 1 month apart, although, that study's just shown that that could still reappear, or for at least 12 months after resolution of symptoms. So I think, practically on the ground, that's what you're going to say to people, isn't it? Either don't have sex for 12 months or you need to be using condoms.
Yeah.
The WHO actually does provide guidance on safe sex practice for survivors and their partners. It is from 2016, so it's not the most up to date, but one imagines it's not a lot different. And we've included the link there on the transcript for people who'd like to discuss that with their patients. I think it's really important.
It is really important. Yeah, fantastic.
Yeah.
Interesting to look at other bodily fluids. So the virus has been detected in sweat up to day 40, in the urine up to day 30. And conjunctival fluid up to day 22, in the feces up to day 19, and breast milk up to day 17, even in the absence of viremia, so even when the virus is not in the bloodstream.
Right.
Women should be advised not to breastfeed during infection unless breast milk has been shown to be PCR negative for Ebola virus, but I'm not sure how available breast milk testing would be. But the risks of not breastfeeding may outweigh the risk of breastfeeding if the infant is symptomatic or there is no safe alternative. So as always, it's about being pragmatic as well,
isn't it? Yeah. So those are lots of things to think about. Let's move on to prevention, because actually that's what we always want to be doing, isn't it? We want to be preventing getting these illness. Just remind ourselves. So Ebola outbreaks are never controlled by a single intervention. Successful outbreak response relies on a combination of public health measures working together. These include, firstly, case identification and isolations. We know that during the 2014 to 2016 West African outbreak, delays in recognising Ebola cases allowed infected individuals to travel between communities and healthcare facilities, accelerating spread. And sadly, this has happened again, hasn't it?
Exactly. I think exactly that. It's been very late that it's been recognised that there is Ebola outbreak.
Yeah.
The next one is contact tracing. And really interesting, one infected traditional healer's funeral in Sierra Leone was linked to approximately 300 cases.
Oh, gosh.
And that demonstrates just how rapidly transmission can occur when contacts are not identified and monitored.
Infection prevention and control. So the deaths of 800 healthcare workers during the large 2014 to 2016 epidemic highlighted the importance of PPE and its availability. Oh my gosh, that's so important. Staff training and safe clinical practices. And you mentioned that in part 2, didn't you? Like, does this test need to be done? Will it change the patient's outcome? Will it put the staff at risk? And that was such an important thing to be thinking about. So we often just think about staff protection in terms of PPE. Have they got PPE? But it's much broader than that, isn't it? It's about effective training, making sure they know how to use it properly, supervision, the buddying thing that you talked about with checking each other's PPE, safe staffing levels. I mean, that's a global problem. Adequate rest periods, because if you are not rested, you make errors, don't you?
Yeah.
And a robust occupational health support. As I've just said, simple measures such as buddy systems for donning and doffing PPE can really significantly reduce the risk of accidental exposure. Yeah.
And just as importantly, actually, and something that I don't know if I'd really thought about it in any great detail, but healthcare workers caring for patients with highly dangerous pathogens face considerable psychological stress.
It just stresses me out even thinking about it.
I mean, when you say that, it's so obvious, isn't it?
Yeah. I think we particularly doctors, just taught that we are, and I don't even know that we're taught it in words, but that we are superhuman, that we never get ill. It's an assumption, isn't it, that we will just cope with everything.
So these healthcare workers may be working in these physically demanding PPE. They'll be making difficult clinical decisions, worrying about their own safety, worrying about their family's safety, and coping with the death of patients and colleagues. So actually, the access to psychological support, peer support programs, and a structured debriefing can help reduce burnout, anxiety, and longer-term mental health consequences. And I think that is really important, particularly the debriefing. Everyone needs to be able to offload.
Safe and dignified burials. So these are really important, that we know in lots of countries, traditional burial practices involve washing or touching the body. And that's probably why so many people got infected, wasn't it, at that healer's funeral that you were talking about, washing or touching the body is recognised as a major driver of transmission in several outbreaks because the virus is so highly concentrated in the deceased because they've got this huge viral load, which is why they've died. And really important that people are given good and safe burials, but also, dignified. And I'm going to move on from that, Minnie, to talk about community engagement, because
they go hand in hand, don't they?
They do, don't they? Because in some outbreaks, and I'd say probably in all of them, that the mistrust of authorities have left people to avoid treatment centres or hide sick relatives. That if they don't understand what you are doing and the reasons for it, if they don't understand why you are burying people in a different way to how they want to do it and they feel is respectful, then they're not going to bring their relatives. They're going to hide them and they go bury them in the traditional way and put even more people at risk. And we've seen that. We saw that in the big epidemic in West Africa, and we're seeing it a bit in DRC, where the funerals are being interrupted. People are trying to take the bodies away and just putting everyone at risk. So it's so important to work with the local leaders, to work with the communities. It's really essential to improve cooperation and to help with outbreak control.
And then surveillance and laboratory testing. Rapid diagnosis, as we know, allows isolation and contact tracing to begin quickly. And the delays in detecting the current Bundibugyo outbreak may have contributed to the large number of cases before control measures were implemented. I mean, and that sort of runs through all of these, really, doesn't it?
It does, and there are some, terrifying reports coming out, aren't there, that are saying they think this may be the worst outbreak ever because they think it's spread so much before they even realised. Yeah. And then finally, vaccination, and we're going to talk about this, aren't we, in a bit, that during outbreaks caused by the actual Ebola virus, so ortho-Ebola virus, Zeranese, ring vaccination strategies, which I'd never heard of, but again, we're going to explain what those are, have been used successfully. So vaccinating contacts and contacts of contacts around a confirmed case to create a buffer of immunity and to interrupt transmission. So that's brilliant if you've got a vaccine, but at the moment for this current outbreak we don't.
But understanding how vaccines work, first it requires an understanding of the immune response to the Ebola infection. So we're just going to explore that a little bit now before we go on to talk about the vaccine, I should say, itself. So it's likely that survivors of infection acquire lifetime immunity to the same species of ortho-Ebola virus that they have had. Evidence from survivors of the 2014 to 2016 West African Ebola epidemic demonstrates that natural infection induces robust and durable immunity, which is fantastic. So in one study, 96% of survivors had detectable neutralizing antibodies, which is crucial that they are neutralizing, and 87% demonstrated virus-specific cellular immune response, with both remaining stable for up to 3 years after infection.
So these findings suggest that survivors develop long-lasting immune memory involving both antibodies due to this high titers of neutralizing antibodies and T cells, providing evidence that naturally acquired protection against Ebola can persist for several years after recovery. And we've put a link to an article that talks about that from the Lancet. So that's in the transcript.
Really interesting.
As a consequence of this, so whilst that is really interesting in itself and absolutely great that you've survived and hopefully you will never have that infection again, but as a consequence, patients who've recovered from infections have actually become invaluable, potentially in caring for patients with active infections. And also, we know, don't we, that they've been valuable in helping produce the therapeutics, the monoclonal antibodies, which we talked about in part 2.
Despite all this, though, our understanding of viral persistence in immune privileged sites remains incomplete, really. There are a few cases that report on the persistence of the virus, as we talked about a bit already, and either reactivation or transmission of the virus. So there are a few examples that we've got which show how it can be very different. One expatriate healthcare worker presented with meningoencephalitis. They had a positive RT-PCR in the CSF and plasma for the virus 9 months after recovering from severe Ebola disease in 2015.
That's so unlucky, isn't it?
Then another example is the case of a late onset encephalitis and polyarthritis, which was reported as a case of possible transmission for a persistently infected survivor over a year after recovery. It's quite frightening, isn't it?
Yeah, it's terrifying, isn't it? So the possibility of prolonged persistence and late re-emergence of clinical disease will probably alter the epidemiological and clinical approach to survivors who present with subsequent illnesses, isn't it? I mean, you'll be wanting to say to these people, have you ever had Ebola? So you can then rule it out. It's also a theoretical concern for the management of women who subsequently become pregnant soon after recovery from acute infection. What does that mean? Yeah.
Now let's have a think about vaccines. That's what we've been promising. So the findings from the survivors suggest that recovery generates this durable immune memory, providing protection against future exposure. And understanding this has been fundamental to the vaccine development, because we know the goal of vaccination is to safely stimulate this same protective immune mechanism without the risks associated with the infection itself.
Vaccination has become one of the most important advances in Ebola outbreak control, but we have said this many times, the only current licensed vaccine is against Ebola virus and not the other two strains. So there are candidate vaccines in development, but efficacy data remains limited. And really importantly, there is insufficient evidence to recommend the current vaccine, which is called Ervebo, as protection against Bundibugyo in the current outbreak. So, we have a vaccine, but we can't use it at the moment. There is no evidence to suggest that it will be helpful.
Yeah, but this, as you have said before, Fran, this course is about all Ebola virus disease. So we will talk a little bit about this licensed Ebola vaccine. It's been pre-qualified by the WHO for Ebola disease virus caused by Ebola virus. And as you said, it's called Ervebo, that's its trade name, and it's administered in one dose.
Brilliant. That's what you want, isn't it? An outbreak, a one-dose vaccine. You don't want to be going back and revaccinating.
No. So it's a live attenuated recombinant vaccine that uses a vesicular stomatitis virus vector engineered to express the Ebola virus glycoprotein. As I said, it's given as a singular dose, but it's an IM injection, intramuscular injection, and it's approved for individuals aged 1 year and older. And if you want to have a look more into vaccines, during our COVID course, we did explain all the different types of vaccines. So we will put a link so you can have a read of those if you want to know a bit more about how these vaccines are created and work.
The Ebola vaccine induces both antibody and cellular immune responses, so protection develops rapidly, making it particularly useful during outbreak. Ring vaccination studies have demonstrated very high efficacy with no cases occurring in vaccinated individuals from approximately 10 days after vaccination. So, I mean, that's pretty impressive, isn't it? No cases. But real world effectiveness, because, nothing is as good as the studies show, was estimated at around 94%, which is still pretty amazing. Yeah.
Antibody responses have been shown to persist for at least 5 years as well, although the exact duration of clinical protection remains uncertain. And the vaccine has generally been really well tolerated, with the usual sort of common side effects of vaccination, including fever, fatigue, headache and muscle aches, joint pain and local injection site reactions. Serious adverse events have been uncommon.
We've got a link here to an article from the SAGE group. They are the Strategic Advisory Group of Experts, about their recommendations for Ebola vaccine. So have a look at that if you're interested. And, if there is a confirmed Ebola virus outbreak, the vaccines can be accessed through an international coordinating group on vaccine provision. Again, we have a link there. And then for preventative vaccination of healthcare and frontline workers, vaccines can be requested through the Gavi preventative Ebola vaccination. And again, we have a link there.
Fantastic. So let's have a think, who actually is eligible for the Ebola vaccine during an outbreak? There are two main groups. The first is all people who've come into direct or indirect contact with a confirmed or probable case. And then, as you mentioned, Fran, frontline and healthcare workers, because they are at the highest risk of contracting the disease during an Ebola virus disease outbreak response. Included here are clinicians and nurses who treat patients, surveillance and contact tracing teams, laboratory staff, safe burial teams, community workers, traditional healers, drivers and other community key stakeholders who are likely to interact with confirmed or probable cases. And I think those other groups, other than the sort of direct healthcare workers, that it's really important to highlight that.
And I think I really thought about that, isn't it? It was during COVID when they're like, who are key workers? And so you know that your key workers are your clinicians and your nurses and stuff. But actually, like you said, it was the delivery drivers who are actually key workers. Nobody can get food if nobody can deliver the food. You know, actually the people who are affected and who we need to protect is much wider than just those working in the hospital, isn't it?
Yeah. Yeah. And, you know, they are also the ones that are in contact with a lot of people.
Yeah.
So if they become infected, then their contacts are huge.
Yes, absolutely. Yeah. So we know that there's the vaccine and it is for Ebola virus, but what about the other species? So there are several candidate vaccines at different stages of development, and as part of the outbreak response, there's a protocol to evaluate the safety, tolerability, immunogenicity, and efficacy of vaccine candidates. And we've put links to that if you're interested in vaccine development.
Vaccination strategies are important, and we're going to talk a bit about those and answer some questions about vaccinations. Fran, tell us, what is ring vaccination?
Finally, we get here. Okay. So vaccination is typically delivered by ring vaccination strategies. This strategy is a way to contain disease outbreaks by vaccinating the close contacts and potential contacts of a confirmed or probable case, creating a ring of immunity around the case to prevent transmission. So someone is listed as a contact when he or she has been in touch with the body fluids, so blood, vomit, saliva, urine, feces, breast milk, or shared the linens, clothes, dishes, or eating utensils of a person with a confirmed or probable status of Ebola disease. You know, potential contacts are neighbours, family members, or extended family members at the closest geographic boundary of all contacts, plus obviously the household members of the contact. So basically, you've got the person in the middle, and then you're vaccinating all the contacts around them to sort of prevent it spreading wider. So that's why it's the ring around the case.
So there are other vaccination strategies, and another one is called targeted geographic vaccination strategy. And this involves vaccinating everyone in the neighbourhood or village rather than vaccinating only the known contacts and potential contacts, which is what you're doing in the ring vaccination strategy. So this approach can be used when the cases are contained within a small geographic area, or when contact tracing is difficult. For example, if it's an area that's difficult to access, or when contact tracing is not feasible, as in a poor security setting, or as in we're seeing in the DRC with the conflict.
Yeah, okay. That's interesting. So here are some frequently asked questions. So is it possible, Minnie, for a person who's been vaccinated to still get infected with Ebola?
In short, yes, it is, because no vaccine is 100% effective. People who receive the vaccine should continue to protect themselves from Ebola virus vaccine. If a person receiving the vaccine was already infected with the Ebola virus before they were vaccinated, they could still develop Ebola virus disease after they receive the vaccine. And this is because it takes 10 days to 2 weeks for the body to develop immunity once vaccinated. If they develop any symptoms of illness, they should immediately contact the vaccination team. Okay, the next question for you, Fran, is can children, pregnant and breastfeeding women be vaccinated?
Yes, the Strategic Advisory Group of Experts on Immunisation, who are SAGE, who we talked about earlier, recommends an off-label use in outbreak settings depending on the risk factor. So the vaccine is licensed from age 1, but in outbreak settings, which, let's face it, Ebola always is, you can use it in children from birth and in pregnant and lactating women. So that means that each country should make the decision on whether or not to offer the vaccines to these categories of the population based on their vulnerabilities and the exposure to the risk of infection. Right, your turn. So can Ebola virus disease survivors be vaccinated?
Yes, indeed they can. So people who survive Ebola virus disease usually develop some natural protection against the disease. And as we talked about, this protection is believed to last for several years, although it may slowly decrease over time. Ebola disease survivors are encouraged to apply all the protective measures against Ebola disease, including vaccination. And obviously, this vaccination is for Ebola virus, not the other strains. So if you've had Ebola virus disease caused by Bundibugyo virus in a Ebola virus outbreak, you definitely want the vaccine.
Yeah.
And for you, Fran, finally, how long does the Ebola vaccine provide protection?
So I think you hinted at this earlier, didn't you,
Oh,
Minnie?
sorry.
No, don't be. It takes between 10 and 14 days to develop a complete immune response. So this means a person can still get infected before the vaccine provides full protection. And Minnie, can people get Ebola virus disease from the vaccine?
No, they cannot. And this is really important to reiterate. It is not possible to become infected with Ebola virus from the vaccine. The vaccine only contains a gene from the Ebola virus, not the whole virus. So you cannot catch it from the vaccine.
That's so important, isn't it, for people to feel safe and
Yeah.
having it. And so we've got 2 case examples. Thank you to the BMJ because we've taken them from there, and they are patients presenting, and we're not going to talk through them because we've obviously described what you should do with patients in quite some detail during these 3 parts, but it's really for you to just reflect on your own and consider what you as a clinician would be doing next in these clinical scenarios. Case number 1, a 35-year-old man is brought to the Ebola screening centre in the DRC with a 3-day history of diarrhea, vomiting and fever. He reports that he attended the funeral of a family member who died from Ebola disease 2 weeks ago. He developed dysphagia and hiccups 24 hours ago, but had been eating normally until then. He has no symptoms of bleeding. On examination, he is found to have a mild conjunctival injection, a faint maculopapular rash over his trunk, mild epigastric tenderness, and hepatomegaly. His vital signs on admission are a temperature of 38.3, pulse rate of 100 beats per minute. His blood pressure is 115/62, respiratory rate 25 breaths per minute, and oxygen saturations of 99%. What would you do next?
And the second case is a 37-year-old doctor who worked in an Ebola treatment centre in the DRC, returned to the UK 3 days ago. She presents with a fever of approximately 12 hours duration, headache and myalgia. She reports sustaining a cut while opening a vial at the treatment centre 10 days ago.
That goes back to you saying, doesn't it? Do you remember how you said don't use the glass vials?
Yeah.
Because you cut yourself easily on them. Yeah.
Just increases the risk, doesn't it?
Yeah.
During her stay, she reports taking atovaquone and proguanil for malaria prophylaxis. There are no abnormal findings on examination except for several mosquito bites. Her vital signs are temperature of 39 degrees centigrade, heart rate of 110 beats per minute, blood pressure of 120/75, and respiratory rate of 25 breaths per minute with oxygen saturations of 99%. What are you going to do next, and what is your differential diagnosis?
Right, well, that brings us to the end of our Ebola virus course. Thank you all so much for joining us on this learning journey. It's been incredibly interesting.
Thank you for listening. And remember, you can download the supporting notes, complete the CPD quiz, and receive your certificate at www.horizonmedicaleducation.com. If you found this episode useful, please share it with your colleagues and follow us for weekly episodes. Goodbye.